of aging in the United States. Students will be introduced to geriatric syndromes associated with aging and aging syndromes. In understanding the aging and health characteristics of older adults, the learner can identify steps to prevent some aspects of aging, which can allow older adults to maintain their independence and remain in the community for as long as possible. Some of the module learning objectives will be identifying changes that occur to the body as adults age, recognize the physiologic, biologic, and psychologic changes associated with aging, identify the steps one can take to prevent the acceleration of aging, understand how pain changes the body both physically and psychologically, and 3, recognize the importance of an active lifestyle and nutrition in maintaining health. Promoting healthy aging is basically living our best life long into our golden years. Today, the United States even has an aging committee that convenes a hearing yearly. The goal of this aging committee is to make sure that healthy aging is a goal for all Americans so that they can strive to achieve longevity and good health. Many important aspects of maintaining longevity and good health have to do with diet and exercise, and we will be discussing that. Americans are living longer than ever before. Older adults are the fastest growing age group. We know that healthy aging starts with community. Staying connected with family and friends helps stave off physical illness and mental decline, and can add years to life and life to years. Aging begins the moment a person is born. A baby develops and matures into adult before we know it. And then at some point, the aging process changes, and the person begins to experience a decline in function. Science can provide information about changes in the body that lead to aging. Science can determine how some of these changes occur. There are still 2 basic mysteries that remain. Why do some people appear to age slower than others? The question as to when a person becomes old can be answered in different ways. Chronological age is based solely on the passage of time. It is a person's age in years. Chronologic age has limited significance in terms of health. Nonetheless, the likelihood of developing a health problem increases as people age. Because chronologic age helps predict many health problems, it has some legal and financial uses. It is also used to determine eligibility for some programs for older adults. Biological age refers to the changes in the body that commonly occur as people age. For example, vision and hearing typically worsen as people age. Because these changes affect some people more than others, some people are biologically old at 40 and others are biologically young at 60 or even older. Psychologic age is based on how people act and feel. For example, an 80-year-old who works, plans, looks forward to future events, and participates in many activities is considered psychologically young. Such a person is commonly described as being young at heart. People often wonder what they are experiencing as they age. Is this normal or is this abnormal? Although some people age somewhat differently, many changes occur in almost everyone and are thus considered normal parts of aging. Geriatrics is a term that refers to the medical care for older adults, an age group that is not easy to define precisely. Gerontology is the study of aging. It includes biologic, sociologic, and psychologic changes. Older is preferred to elderly, but both terms are equally imprecise. It's important to avoid terms and attitudes that suggest bias against older people. Bias against older adults is called ageism. Although there's no set age to define older age greater than 65 is often used because this is the age that determines eligibility for Medicare insurance in the United States. Healthy aging refers to a postponement of or a reduction in the undesired effects of aging. The goals of healthy aging are maintaining physical and mental health, avoiding disorders, and remaining active and independent. For most people, maintaining general good health requires more effort as they age. Certain healthy habits have been shown to reduce the risk of developing several disorders that commonly occur as people age. These habits include following a nutritious diet, exercising regularly, and staying mentally active. The sooner a person develops them, the better. However, it is never too late to begin. In this way, people can have some control over what happens to them as they age. Aging refers to the inevitable and irreversible decline in organ function, which everyone will experience over time, even in the absence of illness or injury. How well organs function depend on how well the cells within them function. Older cells function less well. Although in some organs, cells die and are not replaced, so the number of cells decreases. The number of cells in the testes, ovaries, liver, and kidneys decrease markedly as the body ages. When the number of cells becomes too low, an organ cannot function normally. Thus, most organs function less well as people age. However, not all organs lose a large number of cells. The brain is one example. Healthy older people do not lose many brain cells. Substantial losses occur mainly in people who have had strokes or who have Alzheimer's disease or Parkinson's disease. A decline in one's organs functions, whether due to a disorder or to aging itself, can affect the function of another. For example, in arterial sclerosis, which is a narrowing of blood vessels to the kidneys function less well because the blood flow to the kidneys is decreased. For most people, most of the time, the decline in organ function does not affect the body's ability to function during normal daily activities. People usually notice the decline in organ function only when very demanding tasks are attempted or when a disorder develops. For example, the amount of blood pumped by the heart during vigorous exercise decreases as people age. Older people may notice this change only when they play tennis or jog, and not when they take a walk. They may notice changes in brain function only when they try to learn new information, such as learning a new language. The psychologic, sociologic, and financial situation of older people also affects their behavior. Their behavior in turn, affects their ability to function. Fear or worry may cause older people to become less active. If older people are less active, their ability to function tends to decline. Older people may fear being hurt or embarrassed, so they withdraw from their favorite activities and stay home. Older people with balance problems may fear that they might fall and break a bone. Older people with urinary incontinence may worry that they may have a wedding accident. Not having a partner with whom to share experiences or not having adequate funds may also stop people from participating in activities. People who participate in meaningful activities tend to remain healthy and live longer, as do people who have social support. Married men in particular. Adequate funds, those in higher socioeconomic brackets, and those with a higher education level. There are some physiological changes that happen in the body that come along with aging, and we will discuss them. Primary aging reflects the changes in the body's physiological reserves. This is independent of and not induced by disease. Changes are likely to appear most often during periods of stress. Our genes account for about a 20% probability of a person living to 100 years of age. Healthy lifestyle accounts for approximately 20 to 30%. Promoting optimal nutrition is a must, as I said before. Promoting strength training and exercise will always improve daily functions. As people age, the skin tends to become thinner, less elastic, drier, and finely wrinkled. However, exposure to sunlight over the years contributes to wrinkling and to making the skin rough and blotchy. The effects of exposure to sunlight can be seen when the skin that is normally exposed to sunlight, such as that on the face, is compared with skin that is usually covered, such as that on the buttocks. People who have avoided exposure to sunlight often look much younger than their actual age. The layer of fat under the skin thins and is replaced by a more fibrous tissue. The fat layer acts as a cushion for the skin, helping protect and support it. The fat layer also helps conserve body heat. As this layer thins, the skin is torn more easily, wrinkles are more likely to develop, and tolerance for cold decreases. The number of nerve endings in the skin decreases also. As a result, sensation, including sensitivity to pain, may be reduced, and injuries may be more likely. The number of sweat glands and blood vessels also decrease, and blood flow in the deep levels of the skin decreases. Normally, heat is moved from the inner parts of the body through blood vessels to the surface of the body. When blood flow decreases, less heat leaves the body, and the body cannot cool itself as well. This makes older people more susceptible or more likely to develop disorders such as overheating or heat stroke. Also, as the skin tends to heal more slowly when blood flow is decreased, healing wounds can be a problem. The number of pigment-producing cells, which we call melanocytes, also decreases. Thus, the skin has less protection against UV radiation, such as that from sunlight. Our nails tend to change as we age. They lose their luster, they thicken, and they may become yellowed in color. Some notable changes to the head and neck. A change in vision is often the most undeniable sign of aging. Between the ages of 40 and 50, most people notice that seeing objects closer than 2 feet becomes difficult. This change in vision is called presbyopia. It occurs because the lens in the eye stiffens. Normally, the lens changes its shape to help the eye focus. When the lens stiffens, the eye cannot focus on objects that are close. Many people try to ignore presbyopia for as long as they can, but ultimately, almost everyone with presbyopia ends up wearing reading glasses. People who need glasses to see distant objects may now need to wear bifocals or transition glasses. As people continue to age, vision changes in other ways. Seeing in dim lights becomes more difficult. This change occurs because the lens tends to become less dense. Light passes through the lens to the retina at the back of the eye. A denser lens means that less light enters the eye. Also, the retina, which contains the cells that sense light, become less sensitive. So for reading, brighter light is needed as we age. On average, 60-year-olds need 3 times more light to read than 20-year-olds. With aging, the pupil of the eye reacts more slowly to changes in light. Light enters the eye through the pupil, which widens or narrows to let more or less light in. Consequently, older people may be unable to see when they first enter a dark room, or they may be temporarily blinded when they enter a brightly lit area. This effect is particularly bothersome when a person enters or leaves a dark movie theater or drives in and out of a dark tunnel. Older eyes are less able to adjust, partly because the muscles that widen and narrow the pupils tend to weaken as we age. Older people may also become more sensitive to glare. In other words, Bright light that shines directly or is reflected into the eyes may cause an increased sensitivity. In many cases, this can be due to an eye disorder known as cataracts. Colors are perceived differently as people age also. This change occurs partly because the lens tends to yellow slightly with aging. Yellowing affects how colors at the blue-violet end of the light spectrum are seen. Blues tend to lose their vividness and look more grayish. This change is insignificant for most people. However, older people may have trouble reading black letters printed on a blue background, or reading blue letters. At the other end of the spectrum, red tends to appear more vivid. The ability to see differences in shades and tones and to see fine detail decreases. This change is probably because of the decreased number of nerve cells that transmit visual signals from the eye. This change affects the way depth is perceived, and judging distances may become more difficult. Older people may see more tiny black specks moving across their field of vision. These specks, which we call floaters, are bits of fluid within the eye that have solidified. Floaters do not significantly interfere with vision. Unless they suddenly increase in number, we don't assume that they are a cause for concern. Many older people, however, though, are bothered by dry eyes. This change occurs because the number of cells that produce fluids to lubricate the eye decreases. In some older people, tear production also decreases. The appearance of the eye may change also. The whites of our eyes, or our sclera, may turn slightly yellow or brown. This change results from many years of exposure to ultraviolet light, wind, and dust. Random splotches of color may appear in the whites of the eyes. This is more common among people with darker complexions. Sometimes we see a gray-white ring around the pupil. This is called arcus senilis. It may appear on the surface of the eye, but it has no significance. The ring is made up of calcium and cholesterol salts. It does not affect vision at all. The lower lid may hang away from the eyeball because the muscles that close the eye tend to weaken and the tendons that hold the eyelid in place stretch. The eye may appear to sink into the head because the amount of fat in the area around the eye decreases. The serious eye problems that tend to occur during old age are caused by disorders, not by aging itself. Some examples of disorders that we see in older adults are glaucoma, retinopathy, macular degeneration, and cataracts. Most changes in hearing are probably due as much to noise exposure as to aging. Exposure to loud noises over time damages the ear's ability to hear. Some changes in hearing occur as people age, regardless of whether they have been exposed to loud noises or not. As people age, they may hear less well, and balance may become slightly harder to maintain. These changes occur because some structures in the ear that help with hearing or balance deteriorate ever so slightly. Also, earwax tends to accumulate more as people age. This accumulation can interfere with hearing. As people age, they may notice that they cannot hear high-frequency pitch sounds as well as they used to. For example, they may notice the violin or flute music has lost some of its brightness. Or they may have trouble understanding what women and children, but not men, say because most women and children have higher pitched voices than men. Perhaps more disturbing for older people is that older people seem to always be mumbling. Even when other people speak more loudly, the words are still hard to comprehend. This experience also results from difficulty hearing high-pitched sounds. Most consonants such as C, K, P, S, and T are closed, quick, high-pitched sounds. Vowels are open, longer, and lower pitch. So older people hear vowels much better than consonants. Consonants are the sounds that help people identify words. For example, when a person hears mainly vowels, tell me exactly what you want to keep sounds like, tell me exactly what you want to see. The sentence sounds as if the person is speaking, not pronouncing the words clearly, and the meaning is lost. Speaking loudly does not help because it tends to accentuate the vowels and not the consonants. Many older people have more trouble hearing in loud places or in loud groups because of a lot of background noise. Hearing aids can help people with hearing hear much better. As people age, the muscles used in breathing, such as the diaphragm, tend to weaken. Also, slightly less oxygen is absorbed from air that is breathed in. In people who do not smoke or have a lung disorder, the muscles of breathing and the lungs continue to function well to meet the needs of the body during ordinary daily activities. But these changes may make exercising vigorously, for example, running or biking energetically, more difficult. Older people may also have more difficulty breathing at high altitudes. The lungs become less able to fight infection, in part because the cells that sweep debris out of our airways are less able to do so. Cough, which also helps clear the lungs, tends to be weaker in older adults. Skeletal changes are noted in many older adults. Kyphosis from osteoporotic changes is very noticeable in older adults. As people age, the heart and blood vessels change in many ways. The walls of the heart become stiffer, and the heart fills with blood more slowly. The walls of the arteries become thicker and less elastic. The arteries become less able to respond to changes in the amount of blood pumped through them. Thus, blood pressure is higher in older people than in younger people. Despite these changes, a normal older heart functions well. At rest, the differences between young and old hearts are trivial. The difference becomes more apparent only when more work is required of the heart, as occurs when a person exercises vigorously or becomes ill. An older heart cannot increase how fast it beats as quickly or as much as a younger heart. Regular exercise can reduce the effects of aging on the heart and blood vessels. As people age, bones tend to become less dense. Thus, bones become weaker and more likely to break. In women, loss of bone density speeds up after menopause. Bones become less dense partly because of the amount of calcium they contain decreases. Part of the reason is that less calcium is absorbed in the digestive tract, and levels of vitamin D, the vitamin which really helps our body use calcium, decrease slightly. Calcium is the main mineral that gives bones strength. Certain bones are weakened more than others. Those most affected include the ends of the thigh bone or the femur at the hip, and the ends of the arm bones at the radius and ulnar at the wrist, and the bones of the spine or our vertebral column. In the center of bones is bone marrow, where most blood cells are produced. As people age, the amount of bone marrow decreases. Therefore, fewer blood cells are produced. Even with this decrease, the bone marrow can usually produce enough blood cells to last a lifetime. Problems may occur when the need for blood cells is greatly increased. For example, when a client develops anemia or an infection or bleeding occurs. In such cases, bone marrow is less able to respond to the increased need for production of red blood cells in response to the body's needs. As people age, the cartilage that lines the joints tends to thin. The surface of the joint may not slide over each other as well as they used to, and the joint may be slightly more susceptible to injury. Repeated injury or the lifelong use of joints often leads to osteoarthritis. This is one of the most common disorders of later life. Ligaments, which bind joints together, tend to become less elastic as people age, making joints feel tight or stiff. This change results from chemical changes in the proteins that make up the ligaments. Consequently, most people become less flexible as they age. Ligaments tend to tear more easily, and when they tear, they tend to heal more slowly. As people age, the amount of muscle tissue or muscle mass and strength tend to decrease. This process is called sarcopenia, which literally means loss of flesh. Loss of muscle mass begins around age 30 and continues throughout life. Muscle mass decreases because the number of muscle fibers decreases. This change may occur because the levels of growth hormone and testosterone, which stimulate muscle development, decrease with aging. Also, muscles cannot contract as quickly in old age. Most older people retain enough muscle mass and strength to perform all necessary tasks. Many older people remain strong athletes. They compete in sports and enjoy vigorous physical activity. However, even the fittest may notice some decline as they age. Regular exercise can partially overcome or at least significantly delay the loss of muscle mass and strength. With regular exercise, even people who have never exercised can increase muscle mass and strength. Conversely, physical inactivity, especially during bed rest, during a period of illness, can greatly worsen the loss. During periods of inactivity, older people lose muscle mass and strength much more quickly than younger people do. For example, after one day of bed rest, older people may need 2 weeks of progressively becoming more active to get back to the level of muscle strength they had before that one day of bed rest. As people age, the amount of body fat tends to increase too. Too much body fat can increase the risk of health problems. A healthy diet and exercise can help older people keep body fat from increasing too much. There are changes involved in our movement and motor system as we age. Some of these changes are very common. We know that older adults react and move with less speed. But full range of motion should be unaffected in healthy older adults. Exercise is usually used to mean movement that generates aerobic debt and increases heart rate. For many people, exercise is an important activity with many positive outcomes. However, simple physical activity such as walking or gardening has many of the same benefits for older people. Thus, physical activity without aerobic debt or cardio acceleration is recommended even for those with mobility limitations. All older adults that start an exercise program should be screened by an interview or a questionnaire to identify those individuals with possible chronic disorders and to determine appropriate activities. However, virtually anyone can begin brief periods of walking and increase to 30 minutes 5 times a week. Whether those with chronic disorders need a complete medical examination before starting an activity depends on the results of the tests that have already been done or on clinical judgment of the healthcare provider. Some experts recommend such an examination, possibly with an exercise stress test, for patients who have 2 cardiac risk factors, such as hypertension and obesity, or who plan on starting any activity that would be more strenuous than walking. There are different exercise programs that are more strenuous than walking, and it may include endurance training, muscle strengthening, balance training such as Tai Chi, yoga, Pilates, and flexibility. The combination of exercises depends on the patient's medical condition and fitness level. For example, a seated exercise program that uses cuff weights for strength training and repeated movements for endurance training may be useful for patients who have difficulty standing and walking. An aquatics exercise program may be suggested for patients with arthritis. Patients should be able to select activities they enjoy, but should be encouraged to include all 4 types of exercise. Of all the types of exercise, endurance exercises, walking, cycling, dancing, swimming, low-impact aerobics have the most documented health benefits for older adults. Some patients, particularly those with heart disorders, require medical supervision during exercise. Aging affects the digestive system in several ways, but these changes have little effect on function. The muscles of the esophagus contract less forcefully, but movement of food through the esophagus is not affected. Food is emptied from the stomach more slowly, and the stomach cannot hold as much food because it is less elastic. But in most people, these changes are too slight to be noticed. Certain changes in the digestive system cause problems in some people. The digestive tract may produce less lactase, an enzyme that the body needs to digest milk. As a result, older people are more likely to develop intolerance to dairy products. We call this lactose intolerance. People with lactose intolerance may feel bloated or have gas or diarrhea after they consume milk products. In the large intestine, materials move through more slowly than before. In some people, this slowing may contribute to constipation. The liver also changes. It tends to become smaller because the number of cells in the liver decreases. There's less blood flow through it. Certain enzymes produced in the liver work less efficiently. These enzymes help the body process drugs and some other substances. So as a result, the liver may be slightly less able to help rid the body of certain drugs and substances, and the effects of drugs, intended and unintended, may last longer. Sometimes we have to give lower doses to older adults. As people age, the kidneys tend to become smaller because the number of cells in the kidneys decreases, and there's less blood flow through them. Beginning at age 30, the kidneys begin to filter blood less well. As years pass, they may remove waste products from the blood less well also. They may also excrete too much water, making dehydration more likely. Nonetheless, they almost always function well enough to meet the body's needs. The urinary tract changes in several ways that make controlling urination more difficult. The maximum volume of urine that the bladder can hold decreases as we age. Older people may be less able to delay urination after they first sense a need to urinate. The bladder muscles may contract sporadically, apart from any need to urinate. The bladder muscles weaken, and as a result, more urine is left in the bladder after urination is finished. These changes are one reason that urinary incontinence, or the uncontrollable loss of urine, becomes a common problem as people age. In women, the urethra, which carries urine out of the body, shortens and its lining becomes thinner. The muscle that controls the passage of urine through the urethra, or the urinary sphincter, is less able to close tightly to prevent leakage. These changes result from a decrease in estrogen level that occurs during menopause. As far as men are concerned, as men age, the prostate tends to enlarge. In many men, it enlarges enough to partially block the passage of urine. Most men over the age of 50 develop what is called BPH, benign prostatic hypertrophy. This is when the prostate gland is inflamed, and the prostate gland actually surrounds the urethra, and it makes for an incomplete feeling of emptying when men urinate. And this is a very uncomfortable feeling. It also causes older men to get up more frequently at night with that feeling that they have to urinate. Usually they see a urologist, and there are medications we can give them to shrink that prostate and treat that situation. The effects of aging on the reproductive system are more obvious in women than in men. In women, most of these effects are related to menopause, when the levels of female hormones, particularly estrogen, decrease. Menstrual periods end, and pregnancy is no longer possible. The decrease in female hormone levels causes our ovaries and our uterus to shrink. The tissues of the vagina become thinner, drier, and less elastic, a condition called atrophic vaginitis. The breasts become less firm and more fibrous, and they tend to sag. Some of the changes that begin at menopause may interfere with sexual activity. However, for most women, aging does not significantly affect sexual activity. In men, the changes in the reproductive system are less dramatic. Most men remain fertile until death, even though testosterone levels decrease, resulting in fewer sperm and a decreased sex drive or libido. Most men can continue to have erections and reach orgasm throughout life. However, erections may not last as long or may be slightly less rigid. In addition, the time needed to achieve a second erection may increase markedly. Erectile dysfunction or impotence becomes more common as men age, and we see more erectile dysfunction in men with multiple comorbidities, such as heart disease, obesity, diabetes. The endocrine system has several glands and organs that produce hormones. Hormones act as messengers to help regulate and coordinate activities throughout the body. As people age, the levels of activity of some of the hormones decrease. For example, the level of growth hormone decreases, causing changes in muscle, such as a decrease in muscle mass. The level of aldosterone, a hormone produced by the adrenal glands, also decreases. This decrease may contribute to the tendency of older people to become dehydrated more easily. Most hormonal changes do not affect how the body functions. However, during certain circumstances, the body functions may be affected. For example, after eating a large meal, insulin is released from the pancreas, is not used as efficiently as usual. Insulin helps control the level of sugar in the blood. When insulin is used less efficiently, the level of sugar in the blood rises slightly higher than normal, and the level takes longer to return to normal. This change may have no noticeable effect, but in some people it can be an early warning of diabetes. Acute and persistent pain. Pain is associated with about 80% of clinical visits in the elderly. Almost every older person has pain now and then, and some are unfortunate enough to have pain almost every waking minute. Some older people assume that pain is a normal part of old age and do not seek treatment, or they think that admitting to pain is a sign of weakness. Others fear the side effects of drugs used to treat pain. Feeling bad is bad enough, but pain can also wreak havoc on one person's quality of life and ability to function. Older people with pain may lose sleep and become exhausted. Pain may affect appetite, which can then result in poor nutrition. Pain may prevent people from interacting with others, causing them to become isolated and depressed. Some people become so irritable because of pain that they alienate others. When pain interferes with the ability to carry out daily activities, older people become more dependent on others. Sometimes pain is severe enough to confine a person to a chair or bed, increasing the risk of problems such as pressure sores. The risk of falls may also increase. A chair or bed-bound person grows progressively weaker, creating a potential hazard when trying to get up. The causes of pain are pretty much limitless. Finding the specific cause of pain in older people often proves to be particularly difficult. Sometimes pain has more than one possible cause, and sometimes no cause can be identified at all. To make thinking about possible causes easier, doctors often describe pain as acute or chronic. Acute pain develops suddenly and does not last very long. Acute pain is often caused by an event that has a clear beginning and end, such as an accident or surgery. Chronic pain develops gradually and lasts a long time. Chronic pain has no clear beginning or end, especially when the cause is a chronic disease, for example, arthritis or diabetes mellitus. Pain is often felt in one area of the body when the problem causing it is located in another area. This type of pain is called referred pain. For example, pain due to infection and inflammation in the gallbladder may be felt in one shoulder. Referred pain happens because messages from several areas of the body often travel along the same nerves going to the spinal cord and the brain. Pain may be caused by injury that stimulates the pain receptors. Pain receptors are located at the tip of our nerve cells. When the pain is noted at these nerve cells, when the nerve cells recognize and react to pressure or extreme temperatures, such as hot or cold. This is called nociceptive pain. Nociceptive pain may be accompanied by inflammation, infection, burns, cuts, or a lack of oxygen in the blood. Abnormal nerve activity can cause another type of pain called neuropathic pain. We see neuropathic pain in adults that have experienced shingles or in adults with diabetes mellitus. Diabetes mellitus causes a type of retinopathy and peripheral neuropathy that causes a burning or tingling feeling or numbness in the fingers and the toes. This neuropathic pain is difficult to treat. Occasionally, pain is attributed, at least in part, to a psychological disorder such as depression. Pain is attributed to a psychological cause when no physical cause can be found, and we call this psychogenic pain. Sometimes older adults that are depressed have multiple somatic complaints. Their arm hurts, their neck hurts, their elbow hurts, their leg hurts, everything hurts. Sometimes when they find out that the underlying cause of the pain is depression, and we treat the depression, all of that pain goes away. So it's important when we do a pain assessment to make sure we do a geriatric depression scale. Pain can be described in many different ways: aching, throbbing, squeezing, burning, shooting, stabbing. Pain can range in severity from mild or annoying to severe or excruciating. Because pain is so common, many doctors routinely question people about it, regardless of the reason for their office visit. Neither examinations nor tests can prove that a patient is in pain. Instead, the doctor asks a series of questions. The person's answers may indicate whether the pain is acute or chronic and possibly help identify the causes of the pain. Some questions that the doctor might ask include: how and when did it start? Did it begin suddenly or gradually? Was there a specific event that seemed to trigger this pain? Is there a pattern to the pain? For example, does it get steadily worse as the day goes on, or does it get steadily better with movement? Does it interrupt your sleep? Does it interrupt your activities of daily living? How intense is the pain? What makes it worse? What makes it better? Does pain affect your mood and sense of well-being? Or is the pain accompanied by feelings of depression or anxiety? Questions like these also focus on past and present medical problems that might have a role in causing or worsening the pain. Questions are also posed about current and prior drug use, including pain relievers. Other kinds of questions help the doctor gather more information. For example, a person may be asked to rate their pain on a scale of 1 to 10, with 1 representing a very small amount of pain and 10 representing the worst pain imaginable. Sometimes obtaining information by asking questions can be difficult or even impossible. For example, an older person who has had a stroke may be unable to answer because of the damage to the parts of the brain that control speech. The person may be able to answer yes or no by making sounds, blinking, or raising a finger or hand. The doctor may show the person a series of pictures depicting faces with people experiencing different amounts of pain. Sometimes the person can point to the picture of the face that best represents the amount of pain being experienced. A physical examination can provide useful information. Facial expressions can suggest or even hint at pain. For example, when a person frowns frequently or seems frightened, grimacing, tight wrinkling of the forehead, and rapid blinking or eye closing may suggest pain. The patient may be holding their body rigid or seem to withdraw or guard a painful area when the doctor tries to examine it. Pale skin, sweating, and a fast heart rate may indicate acute pain. The doctor may feel for trigger points which produce pain when touched. Joints are checked for swelling and inflammation. The doctor also moves the person's arms and legs through their normal range of motion to see if any of these motions produce pain. In many cases, pain goes away by itself. When pain worsens or persists, people usually seek relief. Treatment always begins with a discussion between the person, if able, and the doctor. The discussion is an opportunity to review the goals of treatment, the expectations, and possible benefits, as well as risks and side effects of each treatment. Pain is most often treated with drugs, but there are many effective non-drug treatments. Drugs combined with non-drug treatments can result in better pain control than either method used alone. Obviously, some non-drug treatments may be massage, chiropractic care, physical therapy. In addition to these non-drug therapies, the doctor may order some analgesics to help with the discomfort. The first go-to that most doctors use would be non-opiates. The reason we want to go with non-opiates is because we don't want people to become addicted to medication. So non-opiates include things like Tylenol, aspirin, ibuprofen, Aleve. Many of these are sold over the counter. Everything except Tylenol actually reduces inflammation also. So it helps with joint pain and it helps reduce inflammation. So if somebody has arthritis, ibuprofen may help very well. Reducing inflammation often directly treats the cause of pain, and thus providing a cure or control rather than simply pain relief. The problem with using NSAIDs, such as aspirin and ibuprofen, is that they can cause GI distress. Older patients need to be instructed that if they're going to take these NSAIDs, as we call them, non-steroidal anti-inflammatory medications, they should take them with food. When these medications are taken with food, they decrease the risk of bleeding. Obviously, if all aspects of non-opiate drug therapy are explored and adjuvant therapy such as physical therapy, chiropractic care, the doctor may provide some opioid medication to the person. Our concern about using opiates for older adults are the side effects that go along with opiate use. Opiates are the most powerful analgesics. They're used most often for severe acute pain, such as pain after surgery. But sometimes they can be used for chronic pain, such as someone with cancer pain. The ability to relieve pain varies widely among the different opiates. The problem with opiates is that they have many side effects. Many people who take opiates for acute pain become drowsy at first. For some people, this drowsiness may not be a side effect. Rather, it may represent the ability to finally rest now that the pain is relieved. Many people find the drowsiness a welcome respite. Others do not. When opiates are taken regularly, most people stop feeling drowsy. Similarly, many other undesirable side effects diminish. Constipation is an exception. Almost every older person who takes opiates becomes constipated. Constipation continues to be a problem as long as the opiates are taken. Consequently, some people who take opiates regularly must prevent constipation by increasing their activity, increasing their intake of fluids, and taking laxatives. Laxatives that stimulate the large intestine, such as bisacodyl, cascara, and senna, are often used to treat the constipation caused by opiates. Others, such as lactulose or sorbitol, may be used over a longer period of time without damaging the digestive tract. Another problem that goes along with opiate use is that opiates can cause confusion, especially in older people. This side effect may diminish, but often the amount of the drug or the frequency at which it is taken must be decreased. If confusion persists, some people may need to be switched to a different drug. Opiates can also make urination or voiding more difficult, causing the urine to remain in the bladder after urinating. One way a person can try to overcome this problem is by urinating again almost immediately after urinating the first time. We call this double voiding. Opiates can sometimes affect appetite. They may also cause nausea, a particular troubling problem when a person is already experiencing nausea as a result of the pain. Antiemetic medications such as Reglan, Vistaril, Zofran, and Phenergan can help to relieve the nausea. Taking too much of an opiate can cause a dangerous slowing of breathing, coma, and even death. These effects can be reversed with naloxone, an antidote given intravenously. As people age, the number of nerve cells in the brain decreases only slightly. Several things help compensate for this decline. As cells are lost, new connections are made between the remaining nerve cells. New nerve cells may form in some areas of the brain, even during old age. In addition, the brain has more cells than it needs to perform most activities, a characteristic called redundancy. The substances and structures involved in sending messages to the brain. The levels of some chemical messengers, which we call transmitters, and enzymes decrease as we age. Others increase. The number of some types of receptors on nerve cells decreases, and the number on others increases. Because of these changes, the brain function may slightly less well. Older people may react and do tasks somewhat more slowly. Some mental functions may be slightly reduced. This may include vocabulary, short-term memory, and the ability to learn new material, and the ability to recall words. After about age 60, the number of cells in the spinal column begin to decrease. As a result, older people may notice a decrease in sensation. As people age, nerves may conduct signals more slowly. Usually, this change is so minimal that people do not notice it. Also, the nervous system's response to injury is reduced. Nerves may repair themselves more slowly and incompletely in older people than in younger people. Therefore, older people are more vulnerable to injury and disorders. What we know is that age-related losses, such as the death of a loved one, retirement, a diminution in income, decreased physical capacity, and other disabilities sometimes lead to growing social isolation. It can be said that social isolation is a problem for many elderly in today's society. A study was done and they found that older adults that are socially isolated for a prolonged period of time, it's as bad as smoking 15 cigarettes a day. So staying connected with family and friends helps stave off physical illness and mental decline, and can add years to life and life to years. Polypharmacy is a big problem among the older adults. Approximately 80% of older adults have at least one chronic disease and take at least one prescription drug, but actually more than 30% of older adults take about 8 prescription drugs. As a nurse, I can tell you when I go into the hospital, rarely do I have a patient that's an older adult that doesn't have less than 8 medications on their list. It's really important for patients or family members to be aware of all the medications that one takes. I tell my clients to bring all of their medications and supplements with them at their initial visit and periodically thereafter. I can do this to ensure that the person is taking the correct prescribed medication and that the possession of, and I know that the possession of having these drugs doesn't actually guarantee adherence to their medication regime, but at least I'm aware that they have the correct medications in their bag. If someone other than the patient administers the drugs for your older adult, it's important that they be aware of what each of the drugs do. It's also important to ask the person what type of supplements they take, over-the-counter medications. Over-the-counter medications are often forgotten by individuals when they're asked, and it can be important if someone's going for surgery. For example, taking simple omega-3 seems very benign, but if you were going for surgery, the doctor would want you to stop that omega-3 supplement to prevent bleeding. It's also important to talk to people about smoking tobacco and alcohol and recreational drug use when we discuss drugs with them. Patients who smoke tobacco obviously should be counseled to stop. If they do continue, I always counsel them not to be smoking in bed because older adults are more likely to fall asleep while doing so. Patients who use e-cigarettes and vape products should be warned about the risks of nicotine addiction and pulmonary injury. Patients who use recreational drugs such as opiates, alcohol, marijuana, hallucinogens should be counseled about risk of addiction and possible interactions with their prescription and other medications. All patients that come to see a healthcare provider should be checked for signs of alcohol use disorders. Alcohol use disorders are underdiagnosed in older adults. Such signs may include confusion, anger, hostility, alcohol on their breath. Once you've smelled alcohol on somebody's breath, you know exactly what alcohol on one's breath smells like. Impaired balance and gait, tremors, peripheral neuropathy, and nutritional deficiencies. Screening questionnaires and questions about quantity and frequency of alcohol consumption are a must. In fact, in almost every ER you go into, they use a tool to assess alcohol use in older adults. There's different types of tools. There's a tool called the CAGE tool. There's a tool called the alcohol audit. There's also a Michigan alcohol screening test that has a geriatric version to it. It's a 10-question test designed for people over the age of 65 to see if they have a possible problem with alcohol use. The person is asked 10 questions, such as, when talking with others, do you ever underestimate how much you drink? Or, after a few drinks, have you or someone not eaten or been able to skip a meal because you didn't feel hungry? Does having a few drinks help decrease your shakiness or tremors? Does alcohol sometimes make it hard for you to remember parts of the day or night? Do you usually drink to relax or calm your nerves? Do you drink to take your mind off your problems? Have you ever increased your drinking after experiencing a loss in life? Has a doctor or nurse ever said they were worried or concerned about your drinking? Have you ever made rules to manage your drinking? And finally, when you feel lonely, does having a drink help? So this particular audit, called the Short Michigan Alcohol Screening Test, geriatric version, is slightly different than the CAGE audit or the audit use for regular adults, because what we find with older adults, as I said before, they have loneliness many times. By the time someone has reached older age, they've experienced the loss of a loved one, either a spouse, a friend, a child. Many times their children live in other states. They may be lonely. Sometimes people do turn to alcohol as they age, and it can be a problem because when you drink alcohol, it impairs your ability to function properly. And then what do we worry about in older adults? We worry about falls, because falls are one of the geriatric syndromes I'm going to talk about that can actually really cause a lot of disability and even death in some older adults. Geriatric syndromes are diseases that interact with the effects of aging. Because of the decreased physiological reserve when an older adult gets sick, for example, such as having a urinary tract infection, they may not experience the pain that's associated normally with a UTI, and they may become disoriented. This is an example of a geriatric syndrome. Weight loss often accompanies many illnesses in older people because of their changes in smell and taste. So weight loss is actually considered a geriatric symptom for older adults. As our organs age, they're more susceptible to injury. In many cases, the decline we see in elderly is due to lifestyle behavior, diet, and environment. In other words, many cases of geriatric syndromes can be modified. There are some common geriatric symptoms that we see in older adults, and I will discuss a few of them here. First, I want to talk about confusion, because confusion is different from delirium. The prospect of becoming confused strikes fear in the hearts of many older people. Older people fear that confusion will cause them to lose their identity and independence. They also fear that once they become confused, they will always be confused. However, confusion is not inevitable, and if it occurs, it is not necessarily permanent. Confusion has many causes. If the cause can be eliminated or treated, the confusion may disappear or lessen. Understanding what confusion is and what causes it can help reduce the risk of becoming confused. As people age, many changes occur in the brain. These changes make older people more susceptible than younger people to conditions that can disturb mental function. When mental function is disturbed in older people, they usually become confused. Confusion has different meanings, but generally it means that people cannot process information correctly. They can't, for instance, follow a conversation, answer questions appropriately, pay attention to and understand what is going on around them, keep track of information, or remember. Two disorders are characterized by confusion: delirium and dementia. They are very different and have very different causes. However, delirium and dementia may occur together. Delirium occurs suddenly, typically over a period of hours to days. It's usually caused by the recent development of a condition that affects the brain's ability to function. The most obvious symptom of delirium is the inability to pay attention. How well people with delirium are able to pay attention may change over time. They may appear sluggish one moment and alert the next. Often confusion is worse at night. People with delirium may be calm and focused one moment, then agitated and distracted the next. They cannot think clearly and thus cannot speak coherently. If the disorder causing delirium is quickly identified and successfully treated, confusion may disappear or lessen. Then most people can function as well as they did before the delirium developed. As in the case of someone having a possible urinary tract infection, or even simple dehydration can cause confusion and a little bit of delirium in older adults. Sometimes an older adult will be brought into the office by their daughter or their son, family member, and they report that mom or dad is confused. We give them a few glasses of water and they perk right up and they're not confused anymore. So we really do want to look for the reason behind the confusion and the delirium. Dementia develops slowly, and it's usually caused by chronic brain disorder. When dementia first develops, it's unlike delirium. It does not interfere with the ability to pay attention. At first, the most obvious symptom is loss of memory. However, all aspects of mental function slowly decline and steadily deteriorate. Usually, dementia cannot be cured. Eventually, mental function is severely and permanently impaired. The development of a disorder or use of a new drug is more likely to lead to delirium in people with dementia than those without dementia. So in other words, the drugs that are on the market are not working for dementia. Confusion is always serious. People who suddenly become confused or whose confusion suddenly worsens may have delirium. Consequently, they need medical attention immediately. People with sudden confusion are often hospitalized to be evaluated and treated. People who gradually become more and more confused may have dementia, or they may have something else going on, but we know that they need medical attention. Such people rarely need to be hospitalized, but they do need to be evaluated. For them, confusion can be an evaluation over a period of days or weeks during a series of visits to doctors' offices. However, people who have dementia that suddenly worsens need to be evaluated more quickly. The first thing the doctor needs to know about the confused person is whether the confusion occurred suddenly or developed gradually. This information helps doctors determine whether the cause of confusion is delirium or dementia. To be sure of the diagnosis, doctor asks the person a standard series of questions called a mental status exam. These questions help doctors identify which mental functions are not working normally and to what degree. Doctors also talk with a family member or another person who knows the confused person. Such a person can describe how the confused person used to be days, weeks, and months ago, and exactly what has changed. Doctors may ask to see documents that can indicate a change in mental function, such as a checkbook, recent letters, or notification of unpaid bills or missed appointments. For example, a checkbook shows whether the person's writing has changed over a period of time, as well as how well the person can record entries and do math. Letters can indicate whether a person's thinking is confused. Doctors ask other questions to help identify the cause of the confusion. They ask about the disorders the confused person has and the drugs, including non-prescription drugs, and dietary supplements the person has been taking. Doctors may also ask whether the person is taking an illicit drug or consuming a substantial amount of alcohol. Doctors ask detailed questions about the person's emotional health. This information is helpful because depression may be causing or contributing to confusion. Evaluation of confusion always includes a complete physical exam and may include blood and other laboratory tests. Delirium is confusion that begins suddenly and may vary from slight to severe within hours. People who have delirium cannot pay attention or think clearly. Delirium is common among older people. About 10 to 20% of older people who are admitted to the hospital already have delirium. People over the age of 85 are more susceptible. Delirium is a common reason that family members of older people seek help from a doctor or a hospital. Delirium is never normal and always indicates a serious problem. People who have delirium need immediate medical attention. If the cause of delirium is identified and corrected quickly, the delirium can usually be cured. Delirium can be caused by many disorders and drugs and by stressful situations. These causes are especially likely to lead to delirium in people who have dementia. Several disorders can cause delirium in any person, young or old. Examples are infection, stroke, seizures, heart disorders such as a heart attack, an abnormal heart rhythm, and heart failure, and diabetes that is poorly controlled. But in older people, relatively less severe disorders can cause delirium. For example, as I said before, urinary tract infections are a common cause. Other examples are dehydration. Certain drugs can cause delirium in any person, but older people are much more sensitive to drugs. The list of drugs that can cause delirium in older people is long. The drugs that most commonly cause delirium are those that affect the way the brain functions, such as sedatives. But many non-prescription over-the-counter drugs, especially antihistamines, can also cause delirium in older people. Drugs such as antiemetics, antihistamines, some antihypertensive drugs, some antipsychotic drugs, some antispasmodic drugs, some heart drugs, some GI drugs, some muscle relaxants, some opiates, some sedatives, and some drugs for depression. Delirium may also result from withdrawal of sedatives that have been taken for a long period of time. Alcoholics may develop delirium if they suddenly stop drinking alcohol. This type of delirium is called DT, or delirium tremors. Stressful situations may be enough to cause delirium. When a stressful situation is combined with drugs or disorders, delirium is more likely to develop. For example, delirium is common after surgery. That's a stressful situation. The drugs used during the surgery, the pain relievers used after surgery, and complications related to surgery make delirium even more likely in an older adult. People in intensive care units are particularly likely to develop delirium. This is mainly because the conditions in an intensive care unit are stressful. The hospital staff must constantly awaken people during the night to check their vitals, to check the monitor, and to give treatments. People in the ICU don't sleep. People that work there are constantly talking, the lights are on, there's voices and alarms going off constantly. Typically, the rooms in an intensive care unit also have no windows or clocks to help people orient themselves. Thus, there's something called ICU psychosis that we see in individuals that are in the ICU for any extended length of time. Why disorders, drugs, and sometimes stressful situations can so easily cause delirium in older people is not known. However, there are some theories. One theory involves a chemical called acetylcholine. Acetylcholine is a type of neurotransmitters. Neurotransmitters are chemicals that enable the brain to communicate with one another. The level of acetylcholine decreases when the body is stressed, as it is by a disorder, drug, or stressful situation. The brain does not function well without enough acetylcholine. As people age, the brain produces less acetylcholine. Thus, older people are more vulnerable to conditions that cause the level of acetylcholine to decrease even further. Another theory involves chemicals that can harm the brain. We call these chemicals toxins. Toxins may be produced when a person has a disorder, or toxins may be ingested. For example, in contaminated food. Certain drugs are toxic. If the level of the drug in the blood is high enough, these toxins can circulate in the blood. Normally, the body blocks many of these toxins from entering the brain. But as people age, the body is less able to do so. In older people, toxins may accumulate in the brain and prevent it from functioning normally, making delirium more likely. Delirium begins suddenly. Usually family members or friends notice that the person has become mildly or severely confused over a period of hours or a few days. The level of confusion may vary. Often confusion is worse at night. Confusion may worsen, then clear up during the next few hours, only to worsen again. A person may be sluggish one moment and alert the next. A person may be calm and focused, then agitated and distracted. Some people with delirium tend to be anxious and agitated. Very old people with delirium tend to become quiet and withdrawn. In them, confusion is only apparent when someone tries to rouse them or talk to them. People with delirium cannot pay attention, and their ability to do so may vary over minutes or hours. Thus, they do not understand what is happening around them. They become disoriented. They sometimes lose track of who they are, where they are, and what time of day it is. People with delirium cannot concentrate and have difficulty remembering. In conversation, they may wander from topic to topic. Their speech may be slightly slurred, rambling, or incoherent. Many people with delirium do not sleep normally. They may fall asleep during the day, even in noisy places, and stay awake at night. If delirium becomes severe, many people will start to see things and hear things. In other words, they'll start to hallucinate. When confusion begins suddenly, it's almost always delirium. Therefore, people who have recently become confused should be evaluated immediately for delirium. Such people are usually hospitalized so that the cause can be quickly identified and treatment started properly. Often, healthcare practitioners have trouble recognizing delirium. Delirium is especially hard to recognize in people who withdraw and thus do not communicate. Delirium is hard to recognize in people who have dementia because dementia can also cause confusion. In people with dementia, confusion develops over a period of months or years and slowly worsens. If a person with dementia develops delirium, the delirium is identified only if someone notices that the confusion has become decidedly worse over a period of days. Family members and caregivers can help by providing doctors with details about the person's change in mental function, how the confusion began, and how quickly it progressed. The most important information a doctor can obtain is the perspective of someone who has known the person over time and who can describe the recent changes. Family members and caregivers should also tell doctors about all the drugs and any other substances that the confused person may have. This list should include all non-prescription drugs and dietary supplements, as well as any alcohol or illicit drugs used. Doctors perform a physical examination. As part of the examination, the person may be asked questions to determine whether the main problem is an ability to pay attention with this disorientation that results from it. Samples of blood and urine are always taken. Analyses of these samples may help doctors identify the cause of the delirium. Sometimes complex tests are needed, such as CAT scans or MRIs or even spinal taps. When an older person is hospitalized, family members can talk to hospital staff about what measures can help prevent delirium. The following measures may help. Keeping your loved one as mobile as possible. Getting the person out of bed and walking regularly is important. If the person cannot get out of bed, a physical therapist can help the person exercise by moving in other ways. Keeping the person's mind active. Asking questions about the person's life, talking about current events, and reading to the person. Keeping the person oriented. People who wear glasses or use hearing aids should have access to these devices at all times. Placing a clock or a calendar in the room is useful. Explaining tests and treatments reminds people of where they are and why they're there. Encouraging the person to do as many normal tasks as possible, such as dressing. Doing daily tasks helps keep the person active and aware of time of day and makes their life seem more normal. Helping the person get a good night's sleep and making sure that the light in the room is adequate during the day. Thus, the person can stay on a normal sleep cycle to get more restful sleep, and they'll have a better time distinguishing between day and night. Family members sometimes need to talk to nurses about trying to reduce the number of loud noises, such as a loud beeping monitor, or disruptions such as waking the person up to check their blood pressure at 4 o'clock in the morning. Making sure the person drinks enough fluids and eats enough food. The person may need encouragement or help with drinking and eating. Asking staff members which drugs are being used and why. For example, family members can ask whether any of the drugs being used could be making their loved one's confusion worse. If a sedative is being given to help the person sleep, family members can ask about using approaches that have worked at home, such as a warm glass of milk or a cup of herbal tea. If a person is in pain, family members should ask about more effective pain treatments. Once identified, the disorder causing delirium is treated. Prompt treatment of the disorder causing delirium usually prevents permanent brain damage and may result in complete recovery. During treatment, people with delirium may injure themselves, especially if they become agitated or confused. Therefore, they should not be left alone in the hospital. A full-time attendant may be needed to keep people with delirium safe and to care for them. People with delirium may need help and encouragement with getting in and out of bed, feeding themselves, and using the toilet. They may need someone to accompany them when they walk in the hallway. They may need reassurance because they're frightened. family members may choose to provide this care, and nurses can help with it. Nurses can also notice signs of pain, the worsening of any other disorders, and other needs that may be hard to recognize because of the confusion. At every opportunity, family members and staff should help orient a person with delirium to time and place. They should also explain what is going on around them, and that includes the tests or treatments that the person is about to receive. As I said before, if the disorder causing the delirium is quickly identified and successfully treated, most people recover and can function as well as they did before the delirium developed. However, any delay greatly decreases the chance of a full recovery. Even with prompt treatment, delirium may persist for weeks or months, particularly in people who have dementia, to some degree. Improvement may occur slowly. In some people, delirium persists and develops into a chronic disorder that resembles dementia. People who develop delirium while in the hospital tend to stay in the hospital longer than those who do not develop delirium. They are also more likely to develop complications such as pressure sores, urinary tract infections, and incontinence, and fall and be injured. So confusion, delirium, these are symptoms that can really cause a lot of disability for older adults. I want to talk now a little bit about dizziness and fainting. We call fainting syncope. And syncope is something that happens to a lot of older adults. And it's one of the main reasons why we see a lot of older adults in the emergency room. They have what we call a syncopal episode or a near syncopal episode. In other words, either they fainted or they nearly fainted, causing them to fall. Okay? So dizziness and fainting are symptoms. They may indicate that a disorder is present. Both dizziness and fainting are common. They sometimes occur together and have similar causes. But most people who have dizziness do not faint, and many people who faint do not have dizziness. Dizziness makes daily activities difficult and can worsen a person's quality of life. But dizziness rarely indicates a life-threatening disorder. Fainting is less common than dizziness and tends to interfere less with activities of daily living, but it can result in injuries and may indicate a serious or even life-threatening disorder. Dizziness is described as an uncomfortable, troubling sensation that can feel like a spinning, an unsteadiness, or a lightheaded feeling. When standing still, some people feel as if the world is spinning around them, making them feel nauseated. While walking, some people feel their knees go wobbly, and they feel unsteady and shaky. Just after standing, some people sway or feel as if their head is swimming and sometimes drop right back in their chair. Because so many different feelings can be described as dizziness, doctors often try to put dizziness into categories. These categories help people understand each other when they talk about dizziness. And usually we use 4 categories to describe dizziness. One is vertigo. Vertigo is a sensation of motion when there is no motion. It's often described as spinning. Vertigo is what some people have just after they ride a carousel. They briefly feel as though they are still moving, even after both feet are planted firmly on the ground. Disequilibrium is a sense of unsteadiness or loss of balance that involves the legs or the trunk. Disequilibrium may occur while a person is standing or walking. Lightheadedness is a feeling that fainting may occur in the next few moments. Lightheadedness usually occurs when a person gets up quickly after sitting or lying down for a while. Mixed dizziness is a miscellaneous category. It refers to dizziness that does not fit neatly into one of the other 3 categories. It lasts less than a month. It can be temporary or acute. But for dizziness that lasts more than a month, we call this persistent or chronic dizziness. These categories tend to blur into each other. For example, dizziness may seem like lightheadedness and vertigo at the same time, or dizziness may seem to change from one category to another. Older people usually have chronic dizziness, so the categories are less helpful. What's more important is what causes this sensation. Dizziness occurs when the brain gets the wrong or conflicting information about the body's position in relation to its surroundings. Aging itself can cause some parts of the body involved in balance to function less well. But the effect is not enough to cause dizziness unless a person also has a disorder or takes a drug that adds to this effect. Having problems with several of the body parts involved in balance is a common cause of dizziness. In older people, for example, a person may have vision problems, inner ear problems, or vestibular problems, and nerve damage or arthritis, which can interfere with information sent from the joints to the brain. In such cases, the brain does not get enough information to maintain balance and stability. Many disorders can cause dizziness, but among older people, there are two common disorders that cause dizziness. One is called BPPV, benign positional vertigo. The other is Meniere's disease. Benign positional vertigo occurs when the head is moved, for example, when a person lies down, gets up, turns over in bed, or looks up. And when this happens, the person becomes dizzy. This happens because there are particles in the ear called crystals, and these crystals sometimes settle in different areas of the ear, and they clump together. It's pretty simple to treat BPPV, and there are exercises that the doctor can treat an individual to make that feeling go away. Meniere's disease, on the other hand, is vertigo that's usually accompanied by hearing loss, either a roaring or a ringing in the ear called tinnitus, and Meniere's disease is caused by excessive fluid in the inner ear. There is treatment for Meniere's disease. We usually treat Meniere's disease with a medication called meclizine or Antivert. But needless to say, anyone who is experiencing dizziness should report it to their doctor. A doctor will try to identify what's causing it and whether or not they can fit that dizziness diagnosis into a specific category, such as vertigo. The doctor will perform a physical exam, a hearing test. Sometimes the doctor will do an eye test and observe the eyes for any abnormal movements. Sometimes abnormal movements of the eyes or a shaking and oscillating of the pupil can be an indication of an inner ear disorder. The goals of treatment are to correct or possibly prevent, control the cause of dizziness and enable people to prevent or control that dizziness so that they can go about their activities of daily life safely. Sometimes it can be cured. If it's caused by a drug, we stop that drug and change it to something else. If the cause is benign positional vertigo, there's a maneuver called the Epley maneuver, and we can teach the client how to do the Epley maneuver to prevent further vertigo. If it's caused by low blood pressure, what we usually tell older adults to do is to get up slowly. Go from lying to sitting, take a few deep breaths, then go from sitting to standing after they feel steady. These simple treatments usually help people with dizziness feel much better and help control it. Fainting or syncope is a sudden and temporary loss of consciousness. A person who has fainted cannot be aroused for several seconds to several minutes. Fainting can be frightening. People who have fainted open their eyes and find themselves slumped in a chair or sprawled on the floor, just moments after they had been going about their business. They may find themselves surrounded by a throng of concerned people. Some people faint only once. Others faint over and over again. Anyone can faint, but older people are much more likely to do so. Sometimes symptoms related to the cause of fainting occur before, during, and after fainting. People who have fainted may limit their daily activities because their doctor had advised them to do so, or because they're afraid of fainting again. Fainting often results in a fall, which increases the risk of injuries and disability. Most commonly, fainting occurs because the brain does not get enough oxygen or sugar. The brain needs oxygen and sugar to function. These vital fuels are carried to the brain by the blood. If the brain does not get enough blood, the brain may not get enough oxygen and sugar, causing fainting. Or if the level of oxygen or sugar in the blood decreases, the brain may not get enough of them. Many disorders interfere with getting enough oxygen and sugar to the brain and thus can cause fainting. A less common reason for fainting is temporary interruption of consciousness caused by a seizure. As the body ages, blood flow to the brain and the amount of oxygen available to the brain decrease. These changes alone are not enough to cause fainting. But because of them, other problems, certain disorders, certain drugs, and sudden stressful events are more likely to cause fainting. For most older people, fainting results from several problems, not just one. Certain disorders and situations can cause blood pressure to fall. As a result, the brain may not get enough blood and fainting may occur. Blood pressure may fall after standing up quickly. This is called orthostatic hypotension. Or after eating a meal. This is called postprandial hypotension. Coughing strenuously, straining when having a bowel movement, or urinating under certain circumstances can cause a fall in blood pressure and can cause one to faint. Blood pressure may fall when a person becomes dehydrated. Fainting can also result from overstimulation of the vagus nerve, which helps control heart rate and blood pressure. Stimulating the vagus nerve causes the heart rate to slow and blood pressure to fall. This type of fainting is sometimes called a vasovagal attack or a vasovagal syncope. It can result when a person is having trouble swallowing something, is startled, is in a stressful situation, or suddenly has severe pain or becomes nauseated. Some disorders keep the brain from getting enough blood. For example, a heart attack, an abnormal heart rhythm or an arrhythmia, or a heart valve disorder. All of these things can interfere with the heart's ability to pump blood. Fainting is easy to recognize. A doctor focuses on identifying the cause, particularly whether the cause could be life-threatening, such as an abnormal heart rhythm or a heart valve disorder. The doctor begins by asking questions and by performing a physical exam. Often these steps are enough to identify the possible causes of fainting. The doctor asks what the patient was doing before fainting. For example, if the patient had eaten a large meal within an hour before fainting, the cause may be postprandial hypotension. The doctor also asks the person what they felt like before fainting and what the person remembers immediately after regaining consciousness. The symptoms that occurred before, during, and after may suggest a possible cause. The doctor asks whether the person has started taking any new prescription or non-prescription drugs and whether the dosage of any drugs they are on has been changed. Learning about and then avoiding conditions that can cause fainting can help prevent fainting. For example, older men who have felt faint or have fainted while urinating can sit down when urinating to avoid this. Avoiding straining during a bowel movement can help prevent fainting also. If needed, a stool softener can be used or the fiber content in their diet can be increased. For people who must continue taking a drug that increases the risk of fainting, lying down after taking the drug, for example, or taking the drug before going to bed can help. If fainting occurred after eating a large meal, eating smaller, more frequent meals that are low in carbs and lying down after eating can help. Antihypertensive drugs, if being used, should not be immediately taken before a meal. For people whose blood pressure falls when they stand up, drinking plenty of fluids and increasing the amount of salt consumed can help this. These measures increase the amount of fluid in the bloodstream and thus keep the blood pressure from falling. However, consuming too much salt can be dangerous for people who have heart failure. People should consult a dietitian or a doctor before they change their diet. Treatment for fainting basically focuses on several areas. Any injuries due to the fainting should be treated. If a potentially life-threatening disorder such as an abnormal heart rhythm, a heart attack, or a rapid bleeding is suspected, hospitalization and immediate treatment should remedy that situation. Measures are taken to control or correct any other possible causes or conditions that can contribute to fainting. If the cause of fainting appears to be orthostatic hypotension, which we see in a lot of older adults, increasing a small amount of salt in the body or wearing waist-high support hose and raising the head of the bed can help. If orthostatic hypotension occurs after a long period of bed rest, the patient needs to be instructed to sit on the side of the bed for a few minutes before getting upright. If the cause is a sinus syndrome related to a defective pacemaker in the heart, sometimes the patient needs to have an implantable pacemaker placed. Drugs that may increase the risk of fainting should be discontinued whenever possible or replaced with another drug less likely to cause fainting. People who have fainted several times can get a personal emergency response system or a medical alert device. Most of these symptoms include an alert button worn on a necklace. Pressing the button can be a call for help. Most people who faint, though, recover quickly within minutes. However, fainting can cause injuries when a person suddenly falls to the floor. Older people may bump their head or break a bone. Sometimes the fracture is a serious one, such as a hip fracture. Many older people fear falling, and with good reason. Falls are common among older people. About 1/3 of older people who live at home fall at least once a year. Those who are hospitalized or live in a nursing home fall more often. Falls often cause injuries. Some of the injuries, such as a broken hip, can be serious. Older people are more likely to break bones in falls because many older people have what? They have porous, fragile bones. Fear of falling can lead to problems. People worry about doing their usual activities, and then they lose their self-confidence. And if they lose their self-confidence, they can even lose their independence. Older people can do many things to help overcome their fears and reduce their risk of falling. Knowing what causes the fall is most important. If it's caused by the person's physical condition, hazards in the environment, or potentially hazard situations, we can change that. As you can see, the importance of caring for self and others is imperative in older adults. Preventative medical care focuses on preventing health problems from occurring. It's better to prevent someone from falling than to treat them after they've already fallen. Preventative care also focuses on diagnosing problems before symptoms or complications arise, when the chances of recovery are greatest. Although beginning at an early age is best, it's never too late to start on the road to prevention. If an older adult smokes, I suggest they stop smoking immediately. I inform them that the lung begins to make healthy tissue as soon as you stop smoking, even if they've smoked for 20 or 30 years. Same thing about drinking alcohol. When I use my alcohol use disorder tool, I discuss the problems that occur if somebody drinks alcohol alone, and I suggest that possibly the person stay more connected in the community. So studies have shown that people who remain active and who interact with other people during old age live longer, they're happier, and they have healthier lives. Volunteering, taking classes, joining social groups, engaging in hobbies, and pursuing some type of spiritual or religious practice are all ways of staying connected. Even people who are confined to their homes because of illness can stay connected by having others visit them or by communicating over the telephone or by email. Volunteering allows an older person to use skills and life experiences in a way that contributes to the community and society. Hundreds of organizations across the United States welcome older volunteers. For example, the Retired Senior Volunteer Program, or RSVP, and the Foster Grandparent Program provide volunteer opportunities in many communities. Opportunities are also limitless and include working with children, working with older adults, and helping out in nonprofit organizations, such as libraries and assisting small businesses. Being a lifelong learner can be very enjoyable and an effective way of maintaining an active mind and of meeting and interacting with others who have similar interests. Many public school systems and local colleges and universities offer continuing education classes for people of all ages, as well as classes specifically developed with older adults in mind. These classes range from preparing tax returns to managing personal finances or even learning a new language. For older people, hobbies can help maintain social connections, as well as mental and physical fitness. People may develop new hobbies or rediscover hobbies from earlier years. Although many hobbies can be done in solitude, engaging in a hobby with another person or with a group can be more interesting and stimulating. Hobbies that involve physical activities such as gardening or sports can be particularly beneficial to the person's health. Spirituality and religion provide meaning, comfort, and a sense of belonging to many older people. Spirituality and religion are similar but not identical concepts. Religion is often associated with institution, structure, and tradition, whereas spirituality is more associated with feelings, thoughts, and experiences. Most older people in the United States consider themselves both religious, and spiritual. The benefits of exercise can never be overstated. We know that individuals that exercise have reduced mortality rates, even for smokers and obese people. It helps preserve our skeletal muscle strength, aerobic capacity and bone density, and it contributes to greater mobility and independence. Exercising can improve our functional ability, help prevent falls and fall-related injuries by improving muscle strength and balance, and gives an individual an enhanced sense of well-being. Exercise should include the three main types: endurance or aerobic, strengthening, resistance, and stretching or flexibility. Balance exercises are also important. Aerobic exercise requires that oxygen from the air get through the bloodstream to the muscles, where it is used to produce energy. Thus, the heart and lungs are forced to work harder than normal. Aerobic exercise strengthens the heart and lungs and supplies the body with larger amounts of oxygen-rich blood. Aerobics also burns many calories. To be aerobic, exercise must be continued for at least 20 minutes, according to many experts. Walking, running, biking, rowing, swimming, dancing, and skating are all aerobic exercises. Aerobic exercise should be done 3 to 7 times a week. Strengthening exercise involves contracting muscles against resistance for up to 6 seconds at a time. Holding a contraction longer can increase blood pressure too much. There are two types, isotonic and isometric. Isotonic exercise involves moving the muscle against some sort of resistance, such as a rubber band or a gravity weight. Weights may consist of cans of food or milk jugs filled with sand. Isometric exercise involves contracting a muscle without moving a joint. The muscle is contracted and released several times. For example, Kegel exercises, the muscles around the vagina, urethra, and rectum. The muscles used to stop the flow of urine are contracted and then relaxed several times. The main purpose of strengthening exercise is to make sure that muscles get stronger. Strengthening muscles is particularly important for older people because as people age, the amount of muscle mass tends to decrease. This type of exercise also benefits the heart and the lungs, but not as much as aerobic exercise. Strengthening exercise does not burn as many calories as aerobic exercise, but it increases muscle mass and strengthening, and eventually leads to changes in the body that make the body burn more calories. Strengthening the legs help with balance because balance requires strong leg muscles. Strengthening exercises should be done about 2 to 3 times a week. Exercises for the same muscles should not be done 2 days in a row. If a pool is available, aerobic strengthening and stretching exercises can often be done in water more easily than on land. Water provides resistance that improves endurance and strengthens muscles. Water takes some stress off of the joints. It also provides support so that people are less likely to lose their balance. Some pools are designed specifically for exercise or therapy. In these pools, the water is not deeper than mid-level chest. Some communities offer water aerobic classes. Walking laps in the pool can also provide similar results. Before starting exercise, people with any type of disorder should talk with their doctor. If people have several disorders such as heart failure and arthritis, deciding on an exercise program can be more complicated. The help of a doctor or trainer who specializes in helping older people is needed. Some disorders such as unstable angina, abnormal heart rhythm, which is not controlled, and severe heart failure prevent people from exercising. When starting an exercise program, people who have a disorder that limits their physical activity need supervision and instruction, at least at first. Attention to the medical history is very important in older adults because their history is usually somewhat more complicated. Often more time is needed to interview and evaluate older patients, partly because they may have characteristics that interfere with that evaluation. For example, the ability to perform their activities of daily living need to be included when assessing an older adult. Eating, dressing, bathing, transferring between the bed and a chair, using the toilet, and controlling bowel and bladder are important to maintain independence in later life. The history and physical should also include any problems that the individual has with hearing, vision, gait, and balance. Obviously, cognition is important to be screened. Several validated screening tests for cognitive dysfunction can be performed, and for depression. We have a geriatric depression scale called the Hamilton Depression Scale that can be used, and we have the SLUMS exam or the St. Louis mental status exam, which are two reliable and validated screening tools. Let's not forget the patient's social interaction network. Available social support, special needs, safety, and convenience of the patient's environment need to be determined by the nurse or the social worker. Such factors influence the treatment approach used. Many institutions use a checklist. Again, neurologic examination for older patients is similar to that of any other adult. However, non-neurologic disorders that are common among older people may complicate this examination. For example, visual and hearing deficits may impede an evaluation of cranial nerves. Arthritis may impede the range of motion in evaluating someone's joint mobility. Signs detected during an examination must be considered in light of the patient's age, history, and other findings. Symmetric findings such as diminished ankle jerks or decreased distal vibration sensation or any other type of neurological symptom may be noted in older patients. Patients should be reevaluated periodically for functional changes, asymmetry, or any new problems. Most people 65 or over continue to live in the community. And even among people 85 and older, more than 78% of women and 88% of men continue to live on their own. By age 65, 1/3 of women live alone, and by 75, more than half do. Because women tend to live longer than men, fewer older men live alone. Some older people are unable to remain in their homes because of help from relatives or outside services. In the past, older Americans typically moved in with younger relatives if they became impaired. Today, many people live in nursing homes when their situation changes drastically, or retirement facilities or assisted living communities. Caregiver support is extremely important for maintaining independence and keeping one involved in the community. When discussing advance directives with an individual, remember, advance directives are basically the patient's wishes regarding measures for prolonging life, and these measures must be documented. Patients are asked what provisions for surrogate decision-making or advance directives have been made in case they become incapacitated and are unable to make decisions for themselves. Patients are encouraged to have an advance directive. Getting patients and their surrogates accustomed to discussing goals of care is important because when circumstances require medical decisions and prior documentation is unavailable or not relevant to the circumstance, which is very common, appropriate decisions can be made. Healthcare proxies have been around since the 1990s, and an advance directive is basically putting your wishes down on paper in a legal document so that someone you trust can speak for you if and when the time comes that you cannot speak for yourself. We don't expect a time will ever come when we can't speak for ourselves or we can't make decisions for ourselves, but it can happen to anyone. It can happen to the young. You can become incapacitated in a car accident or a tragic accident, but more than likely it happens to older people. They get sick and they get sick quickly. And when this happens, decisions have to be made. So it's a conversation that families need to have with each other. How do I want my end days to be? What do I want done to me if all of a sudden the doctor comes to my family and says, this person will never be able to breathe on their own. This person will never be able to eat again. Do I want artificial respiration? Do I want artificial nutrition? These are things that they're not pretty conversations, but they're conversations that every adult should be able to discuss with people they love, so that at the end of the day, my children and my husband will honor my wishes. So should everyone have someone to honor their wishes. So even though they're difficult decisions to make, it's a good conversation to have with an individual, an older individual, either when they're admitted to the hospital or at times they may require patient care. It's something that must be documented. It's nice to have it in the chart. As a nurse, I can tell you if someone has an advance directive and I go in to take care of them in their private home, it's the first document I ask for a copy of, because I need to know what someone's wishes are and legally what's to be done when the time comes that the person's no longer to make these decisions. I need to know who the healthcare proxy is, who their medical proxy is, who the power of attorney is that makes these decisions for this individual that I'm caring for. So it's the last slide in our module, but it's an important decision that should be broached by the physician, by the nurse, by the social worker, by the family. It's a conversation that people need to have. Thank you.